Welcome to MED-MYSTIFY. Today, we are cutting through the noise to completely demystify the complex pharmacological mechanisms of anti-anginal drugs. I'm your host, and in this explainer, we're going to make these critical meds ridiculously easy to memorize for your exams so you know exactly how they work to protect the human heart. Let's get right into it.
All right, picture your heart as a high-performance engine. It operates on this incredibly delicate physiological balancing act. On one side of the scale, you've got oxygen demand. Now, this demand is driven by a few key things: how fast the heart is beating, its contractility, and the ventricular wall tension. Think of wall tension as the volume of blood stretching the heart out. That's your preload, and the resistance it actually has to pump against, which is your afterload. Then, on the exact opposite side, we have oxygen supply. This is all about coronary blood flow, how wide open those coronary arteries are, and the actual oxygen content floating around in the blood. So when that oxygen demand suddenly outpaces the fuel supply, well, that's when we hit a major crisis point.
Here is our roadmap for this explainer. First, we'll look at the oxygen balancing act, then the 4 phases of angina, followed by restoring balance with specific drug classes. After that, we'll do a deep dive into organic nitrates, explore calcium channel blockers, and wrap it all up with a high-yield exam review. Section 1, the oxygen balancing act, supply and demand. So what actually happens when that delicate scale tips in the wrong direction? We meet our main villain, angina pectoris. By definition, this is that classic chest pain or discomfort caused by temporary myocardial ischemia. Basically, it's an insufficient blood supply to the heart muscle. This crisis usually pops up when conditions like atherosclerosis, which, by the way, is the most common cause, or things like coronary spasms, severe tachycardia, or even extreme emotional stress just tip the scales and literally starve the heart of oxygen. Section 2. 4 phases of angina, types and triggers. Now, what's truly sinister about this villain is that it doesn't always wear the same mask. For your exams, you absolutely have to differentiate the 4 specific types. First up is stable, or classic angina. This one's caused by a fixed narrowing of 70% or more, usually from atherosclerosis. It predictably happens during exercise, like, say, your morning jog, and goes away with rest. But pay really close attention to this next one, unstable angina. This is a massive medical emergency where a plaque ruptures and forms a thrombus. It strikes right at rest, ramps up in severity, and can quickly lead to a myocardial infarction. Third, we've got variant or Prinzmetal's angina. This is caused by coronary spasms and shows up as an ST elevation on an ECG, frequently waking patients up in the early hours of the morning. And finally, microvascular angina. This one affects the tiny, small vessels. Interestingly enough, patients with this type will actually show a completely normal coronary angiography, and we see it a bit more commonly in women. Moving on to Section 3, restoring balance, drug classes. The big question here is, how do we act as the mechanics to fix this broken engine? Well, we've got a whole toolbox of pharmacological heroes. Our options include organic nitrates, which act as vasodilators, calcium channel blockers, beta blockers, potassium channel activators like nicorandil, IF channel inhibitors like ivabradine, and metabolic modulators like ranolazine. We've definitely got options. But looking at your syllabus, we're going to focus heavily on the 2 heavy hitters that totally dominate this space: organic nitrates and calcium channel blockers. Section 4. Deep dive into organic nitrates, the vasodilators. Let's pull out that first major tool and see exactly how it defends against ischemia. This sequence right here, it is a massive, high-yield exam point, so let's walk through it step by step. First, the organic nitrate enters the system. Second, it gets converted straight into nitric oxide, or NO. Third, this nitric oxide goes ahead and activates an enzyme called guanylate cyclase. Fourth, that activation leads to a huge spike in intracellular cGMP. And finally, this increased cGMP acts like a giant brake pedal on preload by relaxing smooth muscle. Crucially, it causes venodilation way more than arterial dilation. That means it pools blood in the veins, which massively drops the amount of blood returning to the heart. Less blood returning means less workload, and boom, reduced oxygen demand. Let's meet the star players. When your patient is in the middle of a terrifying acute attack, nitroglycerin is your fast-acting hero. Chemically known as 1,2,3-propanatrial trinitrate, this is absolutely the drug of choice for emergencies. When you give it sublingually, just pop it right under the tongue, it kicks in super fast. We're talking a rapid onset of just 1 to 3 minutes. But a quick heads up on adverse effects. Because it vasodilates so powerfully, patients are probably going to experience throbbing headaches, flushing, dizziness, and some reflex tachycardia. Now, for long-term protection, we switch gears to Isosorbide Dinitrate.
This is our long-acting shield. It uses the exact same mechanism of action as nitroglycerin, but it stretches out that duration of action to keep the angina villain at bay all day. Because of that, it's heavily preferred for the long-term prophylaxis of chronic angina rather than grabbing it for acute, immediate relief.
But wait, there is a super vital clinical catch here. Write this number down right now, 10 to 12. You absolutely must give your patient a 10 to 12-hour nitrate-free interval every single day. If you don't, the patient is going to develop nitrate tolerance. Basically, the drugs just stop working entirely. They completely lose their hemodynamic effects, and you accidentally leave your patient completely unprotected. Nobody wants that. Section 5. Calcium channel blockers explored. Targeting L-type. All right, let's meet our second group of heroes. Think of calcium channel blockers, or CCBs, as the agents that calm the heart down and open up those fuel lines by blocking L-type channels. By physically blocking these specific L-type calcium channels, they decrease the amount of calcium entering into both the cardiac muscle and the vascular smooth muscle. And hey, less calcium simply means less contraction. This results in beautiful coronary and peripheral vasodilation, plus decreased heart contractility, all of which brilliantly reduces that overall myocardial oxygen demand.
We can divide these guys into 3 distinct families, and you definitely need to memorize which family primarily targets the heart versus which one targets the blood vessels. First, we have the phenylalkylamines. This group is highlighted by Verapamil, which primarily acts right on the heart to drastically decrease heart rate and contractility. Second, the benzocaizopines, like diltiazem. These kind of sit in the middle. They decrease heart rate while also giving you a bit of vasodilation. And third, the dihydropyridines. These are easy to spot because they end in dipene. Think nifedine and amlodipine, and these are your highly potent arterial vasodilators.
Let's look a little closer at a standout from that third family. Amlodipine is your long-acting champion of the dihydropyridine group. It literally works a full 24 hours to keep those vessels dilated. And because it boasts the absolute longest duration of action among the commonly used dihydropyridines, it is just a phenomenal choice for managing both chronic stable angina and hypertension at the same time. Now here's a really surprising fact that they love to test on boards. Nibudipine is a CCB, sure, but it is actually a cerebral specialist. Even though it belongs to the dihydropyridine family, it is highly selective for cerebral arteries. Because of this, it's primarily indicated for cerebral vasospasm, something you'd often see after a subarachnoid hemorrhage in the brain. So you actually do not use it for routine chest pain or angina. Crazy, right? Section 6. High-yield exam review. Final comparison. Okay, let's bring everything we've learned together. You might want to mentally screenshot this because you really need to lock this final comparison into your memory. It perfectly contrasts how these different drug classes manage those oxygen scales we talked about earlier. Notice how nitrates heavily decrease demand by acting as the brakes on preload through venodilation. Meanwhile, your dihydropyridines act as the ultimate fuel line openers, massively increasing oxygen supply via arterial vasodilation. And then, sitting right there in the middle, verapamil and diltiazem manage the demand side by directly calming the heart's rate and contractility. So let's leave off with a physiological puzzle for you to chew on. If you had a patient with variant angina and hypertension, which hero would you choose? Think about it for a second. Variant angina means vasospasms, right? And hypertension means we desperately need arterial dilation. Well, a dihydropyridine like amlodipine would be the absolute perfect hero here, relaxing those spasms while simultaneously lowering blood pressure. So what drug class are you going to prioritize for your next patient case? Kindly like, subscribe, and share for such more informative videos. Also, add comment topics on which you'd like to see the next video. We will catch you in next one.